So I've been charged with speaking about the preoperative evaluation of bone loss in the unstable shoulder. It's my disclosure. I have no relevant disclosures relevant to this talk. So we know that instability creates bone loss, and if the more frequently that you dislocate your shoulder, obviously you're going to have more bone losses that occurs over time. And this is a study from Taylor and Arciero showing that bone loss that occurs over time and the propensity for instability with bone loss. And there have been obviously multiple studies have shown that if you have 20% or more bone loss, you're going to have a biomechanical situation that's very poor for maintaining stability, and soft tissue repairs are not going to work well. And of course, a study everyone's read and everybody is aware of, Burkhart and De Beer's study showing the dismal outcomes if you don't address bone loss, particularly in patients that are athletes, they're going to fail. Recently, though, perhaps the threshold for what we consider critical bone loss is changing. This is a study out of Tripler looking at military patients with Tokish and Batani in their group, and they broke down bone loss by quartiles, and they found that although they didn't necessarily have recurrence of instability, the WOSI scores, or the outcome scores, the functional outcomes of patients that had as little as 13.5% bone loss was much poorer. So perhaps the threshold for considering doing something about bone loss is actually much lower. Now, how do we measure bone loss? You know, we've all thought about the adage of measure with a micrometer and cut with a chainsaw. How precise do we need to be before we consider doing bone loss? What sorts of measurements can allow us to be accurate to plan this appropriately and treat patients with a good solid plan? Really, how do I tell the difference between 13.5% and 20%? Can I really do that accurately? There's a whole bunch of techniques that are described, and we'll talk about some of that in terms of what are the methods for doing that. I really like to know beforehand. I think you can make intraoperative decisions, and it's important to do that. But I like to counsel patients and tell patients what am I going to do to them beforehand, and I'd like to have a close to a 90% solution before I ever get to the operating room. And I think that your ability to preoperatively evaluate bone loss is important because it affects not only how you're going to counsel a patient regarding the risk factors of the surgery recurrence rates, but also can affect how you're going to set up a patient for surgery. So this talk is predicated on a couple of assumptions. You have to believe that you think that bone loss outcomes of operatively treated shoulder instability, hopefully all of you do at this point, and that perhaps you also believe that there is a lower threshold than the traditional thought process of 20 to 5%. So what's the most accurate way to measure bone loss? Obviously there's a multitude of studies and even intraoperative assessment that you can do that. And should I be getting a contralateral CT? Should I be buying special software to help me figure this out? Well, there's certainly not a lack of research and papers and studies looking at this. And I would tell you that I think a lot of the studies are flawed, and mostly because of methodological reasons. There's no control group, so a lot of these groups are just looking at one particular method of measuring. They're not two different methods. They're blinded, and so people have a bias in terms of believing that their particular method is better. There's oftentimes there's too few observers, only one observer or two observers. And then a lot of this previous research is really based on identifying that dichotomy of either bone loss or not bone loss, based on that theory that 20 to 25% is important. So perhaps a lot of the previous research isn't quite as sensitive as we need to be. Certainly plain x-rays can be helpful, and they can give you, I think, just a sense of whether or not there's a problem with the bone loss. Certainly the Bernageau view is something that the French use, and in Europe they have the advantage of having a fluoroscopic sort of image to make sure that they're getting the perfect image, and that's not necessarily readily available to most of us here. And so I think really for bone loss, plain x-rays really only give you a qualitative assessment. You're not going to be that precise with making that determination. I think one of the better studies that's out there that I've found was published a few years ago. They basically took these cadaveric models with that method. Here's another study, again looking at quantifying bone loss, and one of the findings again was that 2D CTs are just not accurate for assessing bone loss. So why aren't they accurate? Why are 2D studies, whether it's an MRI or a CT scan, why are they not as accurate? Well, if the patient's not aligned in the gantry perfectly, or if the reef formats are not well aligned, as this example shows on the right from this paper from Matt Preventure, Tony Romeo, and some others, you can actually underestimate the amount of bone loss or have a perceived level of bone loss that's not quite accurate. So you have to be careful interpreting 2D CT scans for analyzing bone loss. So I think, in conclusion, when you're thinking about bone loss, and if you really are trying to decide whether or not you should be doing some sort of a bony procedure on your patient, what you should be getting is a 3D CT scan and getting a reformat with the humeral head subtracted. I think you can do this accurately enough just with the injured side, and I don't think you need to be getting contralateral CT scans for shoulders. Obviously, there's extra radiation and extra costs with that. Now that we've sort of established that 3D CT scans are probably the best way to look at this, even if you don't even use a measuring system like the one study from Bishop's group, there's really no gold standard in terms of which measuring method. I think that there's good evidence to support either doing linear measurements like the image on the right, giving yourself a percentage of bone loss, or doing, for example, the PICO method that Miniachi's group came up with, and fortunately now a lot of our PAC systems have the ability for you to calculate this without any special software. So of course there's bone loss comes in, it's not just on the glenoid, it also occurs on the humeral side, and you need to take that into account. Obviously Boileau with the instability and severity index score recognized just even on an AP, an internally rotated AP view with that Hill-Sachs, that's clearly a risk factor for recurrence. So plain films obviously are helpful still. I think one of the better studies looking at this was the study by Younggirl Ri and Cho and the colleagues out of Korea. And they looked at 107 shoulders with anterior instability, and they correlated their CT findings with arthroscopy. And they wanted to look at the radiographic factors associated with Hill-Sachs lesions that were engaging. And the interesting finding here was that obviously the Hill-Sachs width, and that's I think a helpful measurement there on the lower right where you can figure out the width of the Hill-Sachs on the axillary view, and also the angle with which the Hill-Sachs lesion occurs. The greater the angle, the more likely it's going to be an engaging lesion. So these again are helpful studies and really based on CT scan. Now recently, the glenoid tract concept has moved along, and you can see that based on the degree of reduction with external rotation, there's a particular track in which the glenoid engages or is engaged with the posterior articular surface of the humeral head adjacent to the rotator cuff. And this has been further looked at by DiGiacomo, Itoy, and Burkhart, and they've classified this into on-track and off-track lesions based on the 83% width of the glenoid width. And this method takes into account not only glenoid bone loss but also humeral bone loss. So just as a clinical example here, essentially what you do is you use a 3D CT scan where you determine the overall width of the glenoid and the bone loss. It's not advancing. There it goes. And then you compare the width with the size of the Hill-Sachs lesion, including the existing bone bridge. And if those match or if they overlap, you're going to have an off-track glenoid. This is something obviously you want to plan intraoperatively. They also think that this is something you can look at intraoperatively as well. So in conclusions, when bone loss is a concern, you should obtain a 3D CT scan with a 3D reconstruction of the glenoid and humeral head and get that good on file And then make sure that you consider the contribution of bone loss, not only from the glenoid, also from the humerus. And I think the glenoid tract concept is something that's helpful for doing that. Thank you.